Alrighty, welcome to Module 9. This is arrhythmia practice. We're going to run this in the same way, and I want you to use this practice how it benefits you best, okay? So we're going to get a question. You can pause the video if you'd like, and you can answer it yourself, or you can keep it running, and I'll just jump into my explanation of kind of my thought process and what things we might go through, and then move on to the next. But hopefully this will be a good, full explanation of the arrhythmias that we've gone through. Alrighty, so the general approach that I want you to take when you get an arrhythmia strip is number one, trust your eyes. What stands out? We've gone over what normal looks like. We've gone over some of the patterns. We've kind of cued in what are some of the things that look weird. So trust your eyes. What do you notice first? Okay, start there. Remember, what you notice first is an opportunity to investigate, and then you go from there. And some of the things that you can investigate are, is the rhythm regular or irregular? Is it fast or slow? Are there P waves? What's our P to QRS ratio? And is the QRS narrow or wide? Remember, if it's narrow, we're thinking it's above the ventricles. And if it's wide, we're thinking that it starts in the ventricles. Alrighty, let's just jump into it, okay? So first thing you're going to notice here, first thing I notice, pause it if you need, but first thing I notice is our R to R, and I look at the rhythm, okay? And I see that this distance here is larger than this distance here. But then this distance matches the original distance, and that's the same there. So what I'm thinking is if we just scooted this guy over a little bit, we'd probably have a regular rhythm. But in this case, because it seems like this, complex came early, I'm thinking that we have an early complex, okay? So, other things I'm going to notice. We have a P wave. Our QRS is narrow, okay? I'm not seeing any depression or elevation. Let's look at our answer choices. So ST segment depression, not a sinus tachy. This is greater than that 3 large boxes, so it's not tachycardia. Premature ventricular complex. Well, remember, if this was ventricular, we'd expect it to be wide, but it's not. Second degree heart block type 1, we're not seeing any sorts of variation in our PR interval, so it's not that. And that brings us with our answer, premature atrial contraction. We have a P wave. Starts in the atria. Our QRS is narrow. It just came early. Okay? Now, I think a really important key piece of information here, something I want to emphasize. When in doubt, you do know things. You know things and you can go through the answer choices and you can rule things out. If you don't know what it is, I bet you know some of the things it's not. So always rule out your choices, do your best to narrow it down. And then if you get stuck, let's look at what we know and see if we can piece together something that makes sense. And if you don't know what it is, see if you can piece it together based on some of the roots. And we might face some of those examples and I'll go over them as we kind of get through too. All right, premature atrial contraction. Number 2, pause if you need to, but we're going to keep going. All right, what do I notice? First thing that jumps out to me is this guy right here. I see these are all regular, but this guy, again, just looks like he came early. I see this kind of inversion here into our QRS, but our QRS is narrow. Alrighty, and everything else looks relatively normal. So I think we don't really have a P wave here, or we've got this inverted guy, but if we pushed him over, it'd be regular. So again, I'm looking for a premature complex, and because that P wave is not super present, I'm going to say it's a premature junctional complex. AFib, remember we'd see that kind of chaotic squiggling, we wouldn't have distinct P waves. Sinus arrhythmia is just a variation with usually respiration. So we might see a little bit faster, a little bit slower, but we wouldn't have this distinct one wave is coming early. ST segment elevation, we're looking for that tombstoning, or we'd see a variation from baseline here. So that's our baseline. We'd expect this to be higher, and it's not. And then premature atrial complex, remember to have an atrial complex, it must have a P wave. And we do not have a distinct P wave. We've got this kind of inversion right into the QRS complex, which is more characteristic of junctional. Alrighty, This guy, what stands out? This giant thing in the middle. Looking back again, let's always be careful. Let's analyze. Let's make sure we're not missing things. These guys look normal to me. These all look regular. They've got a P wave, they've got a narrow QRS, they've got a flat isoelectric line. This guy looks big, funky, backwards. Remember, big, funky, backwards, we're immediately going to think of our premature ventricular complexes. Premature, again, if we just bumped him over a little bit, we'd see that we'd have a regular rhythm, but we do not because he's just a little bit early. Ventricular, because he is wide and he's just big and backwards. Alrighty, same sort of thing. What stands out are these guys here, okay? And so we're looking for premature ventricular contraction. And when we look at our answer choices, that leads us to PVC trigeminy. Now, if you don't know what trigeminy means, let's think about it, okay? Tri is 3. Gemini is just going to describe kind of our pattern of the PVC. So every third beat, we've got 1, 2, and 3. And then 1, 2, and 3. So every third beat, we have a PVC that is trigeminy. Bigeminy would be every second beat, or so on and so forth. Wolff-Parkinson-White, if we remember, has that slurring into the QRS complex. Sinus brady, obviously, would be a rate that is slower and normal sinus rhythm still. Junctional tachycardia, we would not have the distinct P waves. We would have obviously a tachycardic rate, and then ventricular flutter, we would see a much more chaotic waveform. Alrighty, so what did we notice here? We noticed that it's fast, okay? We noticed that it's wide. So we're thinking of some sort of ventricular tachycardia from that. Just those two pieces of information. This QRS is wide, and our rate is fast. It's tachycardic. Okay, so looking at our options here, we have ventricular tachycardic polymorphic, and we have ventricular tachycardia, and then we have torsade de poids, which is also a ventricular tachycardia rhythm. So we can get rid of those two because those aren't fast and wide. All right, polymorphic means that it would change shape. This doesn't look like it's changing shape, and torsade de poids has that nice ribbon sort of pattern, and this does not look like that. So our best answer here is ventricular tachycardia, and if I were to make it even more specific, it'd be ventricular tachycardia monomorphic. Alrighty. What do we see? Well, we see our QRS is wide, okay? And when we look at our P to QRS ratio, let's map out our P waves here. We've got a P wave there. This is a P wave. It's buried in the QRS complex. P wave, boom, 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 and boom. Okay, so our P to P is pretty regular throughout overall. And our QRS to QRS is pretty regular throughout, right? But doesn't look like they're talking to one another. Okay, so let's go through our options. Ventricular tachycardia monomorphic, we just had that. We know this doesn't look like that. Supraventricular tachycardia, that would have narrow QRS, and it would also be tachycardic. This is not that. So we're between a second degree heart block type 2 and third degree heart block. And the key here is to remember which heart block allows you to have buried P waves. And the only heart block that you can have a buried P wave is third degree heart block. So that is your answer here. Alrighty. So in this example, we see some P wave. We got a little bit of action going on, but there's literally nothing else. Okay? We don't see a PVC. We don't see any sort of PR intervals, so we can't calculate heart block. Boom. This is asystole. We might have a little bit of action with our P wave, but we are not producing a viable contraction, so this is still asystole. All right, first thing you notice, hopefully it is fast and wide. Fast and wide, let's look at our answers. We got a ventricular tachycardia, we have second degree heart block type 1. We don't have any PR intervals, we can't measure it like that. Torsade de poids, this does not look like a rhythm. Atrial fibrillation, we don't have a chaotic waveform. This also doesn't have a P wave, but we don't have that chaotic waveform that we would expect to see in AFib. And our ventricular fibrillation would also be chaotic. Okay, so it's not that. Our answer is ventricular tachycardia. Alrighty, so what do we see? We see QRS is a little bit wide, and it doesn't look like our P to QRS is 1 to 1. So let's map it out a little bit. We've got a P wave here, and our QRS here. So it's not 1 to 1. It looks like the P waves are pretty regular, but the QRS complexes aren't regular. So if I had to guess, I would say this is probably a second degree heart block type 2. And the reason for that is, remember our poem, right? If some P's don't get through, then you have Mo beats 2. So we have a P wave here, but it does not have a QRS complex. We have a P wave, no QRS complex, but all the other ones are 1 to 1. Okay, so it's not an issue of we have complete dissociation. We don't see any buried P waves like we do in our type 3 or third degree, but we've got P waves. They do not go through, they do not contract into QRS, and so that's going to be second degree heart block type 2. AFib, expect that chaotic waveform. PJC, we would see narrow QRS coming early in the pattern. Wandering atrial pacemaker, our P waves would look different. And ventricular flutter, we would see more wide QRSs, and it would just appear differently than this does as well. Alrighty, let's see here. What stands out? Alright, so this is fast. We've got from R to R, less than 3 large boxes, which tells us that it is greater than 100 beats per minute. So we are in that tachycardic range. Our ratio is 1 to 1, and our QRS is narrow. So using that information, let's see what we can find. Does anything come early or premature? No. This is regular throughout. Okay? Ventricular flutter, this isn't a ventricular issue because it's narrow. Supraventricular tachycardia, that's viable. Sinus tachycardia, that's viable. And first degree heart block. No, that would have a changing in the PR interval. Okay, so we're between these two. How do you differentiate between supraventricular tachycardia and sinus tachycardia? And the big key here is, do you really see the P wave, or is it kind of morphed into it? Remember, sinus means it starts from the SA node. We've got that nice P wave happening. So if you don't see it, we can just say it's above the ventricles or below the ventricles. But we have a pretty clear T wave here, so we're going to say this is sinus tachycardia. Alrighty, first thing you notice, our rhythm is irregularly irregular, which should immediately cue you into what? Atrial fibrillation. So we've got that chaotic waveform here. We have no P waves that are noticeable. And then we have an irregularly irregular rhythm. Our QRS is narrow. That should immediately cue you into AFib and nothing else. This is a beautiful picture. First thing I noticed, ribbon torsade de pois, or torsades. Okay, if you were to break this down a little bit more, you could say your QRS is wide. And remember, you're going to see some points are going to be larger, some points are slower. We kind of make a nice little DNA module here. Torsade de pois, ventricular tachycardia, but specifically patterned. Alrighty, what do we see? We've got a P wave. This one looks different. And then we kind of morph into something. So while we don't really have 1 to 1, there's not really a P wave here. But the P waves don't all look the same, and that's what I want you to focus on, is even though our rhythm, it looks like it's regular, our QRS complex is narrow. If you were to immediately look at it and kind of just jump the gun, you might say that it's a 1 to 1, even though it's not. But the key here is that this waveform looks different from that. Maybe it looks like that, but it's different from that, different from this one, and different from that guy. And so that tells us that we have a wandering atrial pacemaker. We still have these P-form-like things going on, so we still say that it comes from the atria, but it's wandering around, which is why it has different waveform appearance. Okay, so this one we have narrow QRS. We've got some P waves that don't have buddies, QRS complexes. And we don't have any buried P waves. So, what do you think it is? Well, it's probably not multifocal atrial tachycardia. It's probably not third degree heart block because we don't see anything buried. No P waves are buried in the QRS complexes. Second degree heart block type 1, our poem says longer, longer, longer drop. We don't really have a changing in our distance of these PR intervals that we do have. We just have some dropped QRS complexes along the way. And so the best answer here is second degree heart block type 2. Alrighty. So here we've got a narrow QRS. We have a pause of some sort, and we just have to figure out what it is. And so we're going to say this is 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3, 4. Okay. So this is a sinus arrest. Now, why is it not a pause? What do we expect with a pause? A pause, we would expect the rhythm to match. So when we counted our boxes, we would expect this guy to fall right in line. It just took a little break, and then it went right back where it was supposed to. But this isn't the case here. And if you notice, we've got no P wave here, so we've got this junctional escape beat that kicked us back into our sinus rhythm. All right, what do we see? It's fast, it's narrow. We don't really have the P waves, supraventricular tachycardia. It's above the ventricles, it's narrow, okay? Narrow QRS, these guys. But we've got this kind of morphed PT situation going on. All right, buried P, third degree heart block. You can investigate further for this, okay? Remember, we've got P wave, P wave, P wave, boom, 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 boom. Those are regular. QRS is regular. They're wide. They're not talking to each other, and we have a buried P wave, third degree heart block every single time. If P's and Q's don't agree, then you have third degree. All right, what do we see? First thing that you're going to notice, or the first thing that I notice, we've got a regular rhythm, we've got narrow QRS, and if you kind of just quickly glance, everything probably looks normal until you realize that this P is super far away from the QRS complex and it's regular throughout. So if our P's are far from Q's, we're talking first degree heart block. Anything with a PR interval, that's when we're thinking about heart block, remember that. All right, we've got a chaotic waveform. We don't have P waves. We don't have QRS complexes that are narrow. These are wide. The R to R here can't really be determined. So chaotic ventricular issue, this is ventricular fibrillation. All right. What do we see? What do we see? Do we see a sawtooth pattern going like this, and then a QRS, and then a sawtooth, and then a QRS? Nope. So it's not atrial flutter. Junctional rhythm, we wouldn't have these nice, beautiful P waves that are before us. Sinus arrest doesn't really make sense. We don't have a pause or a break or an absence of signal. Sinus bradycardia is our answer. 1, 2, 3, 4, 5. This is greater than 5 large boxes, which means it is less than 60 beats per minute. Remember, you can figure out heart rate however you want to. That's just the quick thing that I do in my head. All right, what do we see? See normal rhythm. P to QRS is 1 to 1. Everything seems to be pretty normal. I think this is actually just a case of normal sinus rhythm. Now remember, when you're given a rhythm strip, I don't really like it all the time when they give you a normal one, but your job is to know what normal looks like. So don't trip yourself up and try to look for a problem. Sometimes it's just normal. All right, what jumps out? Should see that these guys here are close together. These are farther apart, and this is chaotic. What does that tell you? Atrial fibrillation. QRS is narrow. We have a chaotic waveform. No P waves are present, and it is irregular rhythm. Alrighty, that's all I got for you for the practice. Keep working at these, keep practicing. There are lots of different websites that you can use that'll give you kind of the drilled practice. So as much as you can, highly recommend just repetition, repetition, repetition. But again, if you can think about, is the rhythm fast or slow? Is it narrow or wide? Is there P wave? Is it 1 to 1? These are the things that are going to help you figure out and use your little investigative skills that you have now. You got this. Happy studying. Take care.